team, Eddie or Tanya, can you guys see can you see the video and our participants?
Yes.
Wonderful. Thank you so much. All right, so let's get started with our update first because we really want to hear from our special guests as soon as possible. So sadly, as of this morning, DHEC is reporting greater than 250,000 confirmed and probable cases of COVID in our state. Our percent positive has been around the 20% mark for the last week. You may remember we got as low as even 9% on some days. But we've been hovering around that 20% mark. And keep in mind that because we've been testing more, if our incidence and prevalence of the disease stable, we would actually see a slight decrease in that percent positive, but it continues to go up, and that's not surprising given the surge in numbers that we're experiencing across our entire nation. I generally report for you our incidence by county per 100,000 and what risk category that puts each of those counties in. We usually check in with Greenville, Richland, Oconee, and Sumter counties. I'm not doing that today. What you need to know is that every single one of our counties in South Carolina is now in the high risk category, meaning greater than 200 cases per 100,000. And those 4 counties that I generally report to you about are somewhere between 500 and 900 cases per 100,000. So if you hadn't figured it out before, the cases are definitely skyrocketing. And this is the time for us to really dig deep and tend to those precautions: mask wearing, social distancing, hand hygiene. We're really discouraging travel and gatherings right now. Let me just bring you up to date with a few recommendations that will impact you and your employees and your workforce. And then I want to talk to our DHEC guests. So you may have noticed, as I mentioned, there's more testing. It's very available. DHEC has numerous sites where they're doing testing for free. I actually went through this process last week, and I was in and out in less than 10 minutes, and everyone was phenomenally professional and kind. It was a wonderful experience. And this is a good thing because we have more and more folks now who are experiencing symptoms, not just because the COVID numbers are going up, but because it's cold and flu season. And so we want to make sure that we're testing all of those folks who have symptoms. There are airlines that are requiring tests for travel. We want these numbers for public health surveillance, but also we're testing folks who've been exposed, and we're seeing that there are more and more reports of exposure. And part of that is because there are more and more folks who have COVID and therefore more opportunities for exposure. It's also because the weather is keeping us indoors a little bit more, although our South Carolina weather has been lovely. It's because we have been gathering for the holidays, but it's also because the definition of close contact has changed slightly. So you may remember that to have been, quote, exposed or considered a closed contact, that means that you were within 6 feet of someone known to be diagnosed COVID positive for a 15-minute block. Well, now it can be a total of 15 minutes over 24 hours. So some folks may be thinking, I don't really know. I think I may have been exposed. And so we're testing more and more folks who are concerned about that. I want to talk about what happens when someone does feel that they were a close contact, because the quarantine recommendations have officially changed since the last time I sent you all a video. I believe in that video I mentioned they were just about to change them. Well, they did. So now there are several strategies for managing an employee or someone you know or yourself if you come in contact with someone or become a close contact of someone who is diagnosed with COVID. And I'm just going to briefly remind everyone if they could please mute their mics so that we don't have any background noise. That would be great. Thank you so much. So there are now 3 strategies. The optimal strategy is to quarantine for 14 days. That has been the recommendation, and to get tested at 7 days. But regardless if whether that test is negative or not, to continue quarantine for that full 14-day period. That is still optimal. And keep in mind that to truly quarantine, you need to isolate yourself from folks inside your home and outside your home. This can be especially difficult for folks whose exposure the positive COVID contact they had is with someone who lives with them. That can be very tough to do, but that is the definition of quarantining. There are two other strategies that have been have been presented as acceptable, and the other is to quarantine for 10 days instead of 14 days. And this is presuming that the person who was exposed remains asymptomatic and can continue to monitor for symptoms for a full 14-day period. That confers about a 1% risk of transmission. There's a third strategy that is ending quarantine after 7 days, assuming no symptoms were developed, but getting tested around 3 to 5 days. 5 days is optimal. And if that test is negative and the person remains asymptomatic, they can stop their quarantine period at day 7, and then, of course, continue to monitor for symptoms for an additional 7 days. This confers about a 5% risk of transmission. So the thought around changing some of these strategies, or at least offering additional strategies for managing quarantine exposure quarantine times, was that 14 days is highly onerous, and especially if the contact is within your household. That was difficult to do, and quite honestly, folks weren't doing it. So researchers and scientists have discovered that the 10-day and 7-day quarantine procedures confer low enough risk so that it's still safe to come out of quarantine, especially that 7-day one if you've got a negative test, but is much more easily complied with. So folks can much more easily quarantine for 7 days or possibly 10 days than they can for 14 days. And hopefully compliance will go up. Folks will actually do that quarantining and drop our numbers and drop further exposures and outbreaks. Okay, I am going to pause there and check in. Let's see, I've got my participant list up. I know that I saw Dr. Traxler. And do I have Mr. White on the line?
Yeah, Stephen's here.
Great. Thank you so much for joining. So everyone, we have a special treat today. We have numerous guests from DHEC, and I'm going to let Dr. Traxler and Mr. White introduce them to you. But these folks are extremely busy right now, and I am so appreciative to them for taking an hour of their day to meet with you all so that they can answer your questions. We've got Dr. Brannon Traxler with us. She is the Interim Director of Public Health for DHEC. And we have Mr. Stephen White, who is the COVID-19 vaccine coordinator for South Carolina at DHEC. Now, you can imagine these people are extremely busy right now. So thank you so much for joining us. I have asked them to talk to you all about the vaccines that are coming down the pike, a little bit about them, as well as the administration plan for South Carolina, how we're going to phase in vaccination administration, and maybe even mention some about becoming a closed pod. So if you're an organization or business that would like to learn about becoming a closed point of dispensing of this vaccine, we've got some folks on the line that can help you there. So I'm going to mute myself and manage everyone else's microphones and let Dr. Traxler and Mr. White begin to share their expertise with you. Thank you again for being here.
Thank you, Dr. Brown. And so it is an exciting day to be with y'all. As you, I think, all know, the first COVID-19 vaccines are being sent to all states, including ours. The first ones will be arriving in South Carolina at some point today. So this is, a big step towards the end of this pandemic. We're not there yet, but it is certainly a big step. Stephen White is on the line with me. He is in charge of our COVID-19 vaccination response, and is also our non-COVID, pre-COVID, normal times, whatever you want to call it, immunization director for DHEC. So he is really the expert in all things immunization. We also have Whitney Cofield, who is our external plans coordinator for public health preparedness for DHEC, who can shed some of the expertise on the closed pods. And I saw when I was glancing through that we have some of our regional public health preparedness, or PHP staff, also from the Midlands and the Upstate on the line. And I'm not certain, I don't want to start reading out names because I'm not certain that I saw all of them to know, but I saw at least several. So so they really if you don't know them, we'll help get you in contact with them because they're really key people for you all to know locally. Um, and first, I'm going to give you a little bit of background about the vaccines that are kind of in the pipeline right now or are available. And then kind of the FDA process, how this all works with all the acronyms and committees you've heard thrown about. And then I'm going to give it to Stephen to talk about our vaccine distribution plan and to Whitney about closed pods. So both vaccines that we expect to be available before the end of the calendar year, the Pfizer one and the Moderna one, are what we call mRNA vaccines. And this is a new vaccine platform. I say it's new, it's the first ones to be authorized or approved for use. However, research has been going on with this vaccine platform for decades. And it really, that is part of how we were able to get to a vaccine so quickly as part of all of this Operation Warp Speed, is because there was a lot of background research done on mRNA vaccines and even specific to the SARS virus, the SARS-CoV-1, which is very similar to the current one, which is the SARS-CoV-2. The original SARS virus, which led to the disease SARS, as you might remember, was an outbreak back in the early 2000s in 2003, and thankfully smoldered and died out before a vaccine was necessary. But there was a lot of research done that they were able to pick up where it left off. This platform has also been looked at for use in other vaccines more recently. It's shown fairly good response even in Africa when used for Ebola vaccine. But I promise you, is not altering your DNA. That's, I think, one of the myths I've heard of out there about it, is it does not do anything to your DNA. It's not going to change your DNA or become part of your DNA. It literally just causes your body to create the spike protein, which, as we know, is one of those essential pieces on the surface of the cells of the virus, on the surface of the virus, that is really essential for it getting into our cells. And so it codes for this spike protein, but not the whole virus itself, just the spike protein. And so your body then can recognize it as being, foreign and create antibodies to it and create an immune response. And so then if you were exposed to further to the actual virus, it would still recognize that spike protein on the surface of the virus and say, hey, we've seen that before. And those antibodies would gear up and would go in and attack the virus to prevent it from continuing to multiply in you. But it's kind of a long process that's been compressed down into a couple of short weeks here for how vaccines get approval. So you all are probably aware there's 3 phases for clinical trials for vaccines, with some people saying there's a 4th phase. But it's kind of just a post-approval phase. So it goes through phase 1, 2, and 3 trials looking at the safety and efficacy. By the time you get to those phase 3 trials, you're enrolling large numbers of people. So, for example, for the Pfizer and Moderna vaccines that are the ones really that we're thinking about right now, those each were enrolling, 30 to 45,000 people in the United States each, with half being then randomized to receive a placebo, just a saline shot, and half getting the real thing. And they tracked them for at least a couple of months. It had to be the average for how long they were tracked to make sure for safety. And they also, of course, monitored for disease and for symptoms. There is an independent data review committee or board that are the only people who know what's going on in real time with these trial results. They set a threshold. Basically, when we get to X number of infections amongst all the participants in a trial, we will feel confident that we can trust this data. And so part of why we were able to get to that so quickly for these vaccines is, number one, Americans really stepped up to the plate. There was a great response. A lot of people enrolled in clinical trials for it. And so they were able to get the participation. Secondly, unfortunately, this fall, as cases increased, it did increase the risk of exposure and make people more likely to potentially get it. And so they were able to reach that threshold. Once that threshold is reached, this vaccine review data review committee then tells the pharmaceutical company, okay, we've hit a trigger point. Here's what you can do. You can apply for emergency use authorization or during non-emergencies for FDA approval. That data review board is also keeping an eye out for concerning things that they see either in the data or certain events that they see that might be concerning, where they might even pause or stop the trial. So, and for these, they didn't see any of those. So back on December 1st, which seems like so long ago, and it was not even 2 weeks ago, the CDC's committee, their Advisory Committee on Immunization Practices, ACIP, met, and that committee is always who provides recommendations and guidance to providers on who should receive vaccinations, when they should receive them, the schedule, the specifics, really. So they came up with the phase 1A populations that they recommended. And South Carolina's Vaccine Advisory Committee reviewed those and applied them to South Carolina and has adopted them. So phase 1A in South Carolina includes those healthcare providers that are at risk of exposure to COVID-19, as well as long-term care facility residents and staff. On December 10th, the FDA's VRBPAC, their Vaccine and Related Biological Products Advisory Committee, met, and that's who reviews the data for the FDA. They came together and voted to recommend that the FDA apply for an emergency use authorization, or that the Pfizer apply for an emergency use authorization. They recommended that FDA grant that application. And so on December 11th, the FDA gave an EUA, an emergency use authorization, for the Pfizer BioNTech vaccine. It was jointly developed by Pfizer and a German company, BioNTech. The next day, ACIP, that CDC committee, came together again and reviewed the data themselves, as well as the EUA information, and recommended that the Pfizer vaccine could be used in individuals 16 years old or older. Pfizer had done some work on, some of their research had been on adolescents in their clinical trials. So then, I think you all know this weekend there was a flurry of excitement and activity, and Pfizer began rolling out yesterday from their distribution centers those first doses and the first week's allotments to states. And so between today and Wednesday are when locations in all the states are receiving their vaccines. South Carolina will be receiving some each of those 3 days at different locations. And for the record, we didn't have anything to do. That was purely a geographical logistical thing in terms of the which day of the week different places in the state maybe got it. The FDA Operation Warp Speed contracted with UPS and FedEx to do the distribution. In terms of the Moderna vaccine, which is the other one that's very similar, that is out there, it has applied for its EUA. And so VRBPAC, that FDA committee, is scheduled to meet on Thursday of this week to discuss the data for a Moderna vaccine. And we expect their data, from what we hear, is looking good. So we expect an emergency use authorization to be given from the FDA within a day or two after that. And then on Friday and Sunday, ACIP is scheduled to meet to vote on their recommendations. The one difference between these vaccines is Moderna did not study it yet, did not do trials yet on adolescents, so it will probably only go down to age 18 for their recommendation. But so we would anticipate by the end of next weekend, potentially, this time next week, having a second vaccine that's available nationwide. Then what South Carolina has done, as I said, for that phase 1A, we are doing long-term care facilities and the healthcare providers that are really on the front lines. So there are a number of locations in the state that will be getting the vaccine. I think it's in the mid-50s that'll actually be getting vaccine. That's in addition to that, we have elected we have opted into the federal pharmacy partnership, which is with Walgreens and CVS, and they will, we allocated vaccine to them, and they will go and actually do the vaccinations at long-term care facilities for their residents and staff. We anticipate that'll begin by the end of the month. So in terms of the sites in South Carolina that are getting vaccine, some of them are having it sent directly to them, and some are having it allocated through DHEC. So there's a couple of tricky parts about the logistics of the Pfizer vaccine. One is that it has to be stored at negative 70 degrees Celsius, which is extremely cold. It's ultra cold, well beyond your standard freezer. It's pretty impressive when you see the gloves that somebody has to put on just to go into this to get it out. I'm not sure our pharmacists, I'm not sure her hands could work in it. They were so thick and bulky, but those are ultra cold and have only a few days where they can be out, 5 days, then thawed, you know, when you're giving them to folks. The other trick with the Pfizer one is that they only are shipped in allotments or trays of 975 doses at a time. That's the Moderna is a couple of hundred at a time, much easier to allot smaller numbers. So for smaller, you know, hospitals that are getting vaccine early on, but don't need 975 doses at once, then basically DHEC is getting an allotment along with our state partners. It's really the state's RSS site. And that'll be then broken up into smaller amounts and redistributed to facilities. In addition, the ancillary kits, gloves, needles, alcohol pads, all that is being sent from the feds and from the states and are being distributed simultaneously. Let's see, some of our ongoing operations, I wanted to talk on that briefly. We, as I said, have allocated this first week's worth for the Pfizer 1A vaccine, and we do have ongoing planning, and this is where I'm going to turn it over to Stephen to talk about some of our vaccine distribution plan and the phased approach that we're doing. But what I want to say is, before I turn it over to him, is to everyone, please encourage vaccination. Please get vaccinated yourself, but also be patient. You know, this is a time we can all really step up by stepping back and allowing those folks who are at highest risk and are the most critical for saving lives to get the first doses. So I'm telling myself that I'm being patient. I am not 1A, so I will fully admit. So we all, you know, have to wait our turn, but we fully anticipate that, you know, by the middle of the year, we're going to have, you know, vaccine to be getting to everyone. So Stephen, you want to take over?
Sure, I can start taking over. It's a great overview, and thank you for that, Dr. Traxler. And yes, as Dr. Traxler mentioned, I am the ACC immunization chief by day, and by night, I still do my regular job of being the immunization division director for all other routine vaccines, such as flu and routine childhood immunizations and adult vaccines as well. So thanks for having us on. So Dr. Traxler has actually alluded to this already with the different phases of phase 1A, which is again focused on those frontline healthcare workers, at least in South Carolina, it's the frontline healthcare workers that are highest risk for exposure, transmission, et cetera, and then the long-term care facilities. And ACIP, when they came in with their recommendations that they recently came out with, they targeted healthcare workers in general, which for South Carolina was a little bit of a challenge, and we did have to adjust. We've been working with a vaccine advisory committee that's led by our state epidemiologist, Dr. Linda Bell, and Dr. Jane Kelly, who have been helping to facilitate that group. It is a very large group consisting of the hospital associations, the religious groups around the state, AARP, AAP, vulnerable populations, you name it, it feels like they're on it. And they have done a really great job of coming together to discuss the points when there were a lot of unknowns based off of the CDC's interim guidance, or interim playbook, if you will, which they've now come out with a couple iterations of that yet. And so the Vaccine Advisory Committee, which is an advisory body to DHEC to give us considerations for our allocation plans. They've married up what the ACIP has recommended with their phase 1A, and they've married up our initial thoughts, which were not far off at all from ACIP. In fact, they mirrored it quite nicely, except for South Carolina's went a little bit deeper with who we had thought through who would be the first to be getting some of those vaccines. And that information can now be, it's now posted on our COVID-19 website, on DHEC's website. And I'm sure many of you have probably already seen that. And then to Dr. Traxler's point, a lot of folks are probably going to be looking to hospitals to say, well, we want to get vaccinated, and they may not fall in those targeted population groups. So we wanted to be sure to be clear that we weren't having people call up the hospitals to get vaccines and, again, wait their turn as we get more vaccine allocations down the line. So phase 1A has been decided on by ACIP. There's a phase 1B, which is more of your vulnerable populations and those that provide essential services, those that kind of keep the lights on, and they serve essential functions of society, and we can't socially distance in the workplace. So this would be folks like your law enforcement, teachers, food packaging, childcare providers, et cetera. There's a long laundry list of folks that would be considered in 1B. That has not been finalized by ACIP at this moment. And so South Carolina is still looking at with the Vaccine Advisory Committee, they're still looking at the phase 1Bs, and we're working with the Vaccine Advisory Group. It seems like daily we're taking another look at that listing of people to make sure that we have everybody included in that we feel should be getting vaccinations first. There's also some discussions on the national level from ACIP about having a phase 1C. And that phase 1C is, at the moment, they've talked about it being for 65 years of age with different comorbidities. That also has not been decided yet, because there's been some open comment period that ACIP is allowing for people to come in to say if phase 1B and phase 1C should even be flip-flopped, and should be looking at 65 years of age with other comorbidities before we look to those other essential services. So we will hear more from the ACIP, I'm imagining, in the coming weeks. And once we do, we will be prepared from DHEC's point of view and with the Vaccine Advisory Committee to make our recommendations for who should receive the next doses that come into South Carolina. When we get into phase 2, we start talking about more of a general population folks, and obviously in any of these phases, as we move through phase 1A, phase 1B, phase 2, and eventually to phase 3, anybody that hasn't gotten vaccinated in a prior phase we will be looking to vaccinate those individuals, as we anticipate there will be some that won't wish to be vaccinated in the first couple of weeks. They'll want to see how vaccinations work, and may in time choose to be vaccinated at a later time. So we will be looking more of that down the road. So phase 2 is more the general population. Phase 3, though, would be when we start to see that most people by that time would either have gotten vaccinated, and then we're going to also have higher supply. And we're also anticipating that at that time, healthy adults, which are at least risk of all the populations that we have, would be considered for phase 3. And then in time, as Dr. Traxler alluded to, if there's an indication for children, then that at that time, that would be when vaccinations would be looked at that point in time. So how are we going to do it? That's the biggest question. That's the biggest obstacle. And I like to remind all the staff that are there that it's going to take a village. It's not going to be DHEC alone. We're going to be working in partnership with hospital systems, pharmacies, any mass vaccination turnkey vendor, students, whoever is certified to be able to provide the vaccines in time. We'll be looking at all these individuals to assist South Carolina make sure that we're vaccinated. In order to receive vaccines, you have to be enrolled. There's a process for enrollment. I believe all of the Prisma sites, or the hospital sites, at least at the moment, have been enrolled, both for Section A and Section B, meaning that the Section B is the most important, where they actually will receive the vaccines and administer those doses. So we've been working with, I believe it's John Pearson and Jennifer Bear, I believe, in the Midlands. And so they've been very helpful with how we're going to get vaccines to your Prisma sites, both in the upstate and in the Midlands region, and then thus out to all the other hospitals in general. So unless they are enrolled, they can't get vaccines. So we will be also looking at different ways to provide vaccinations to those that don't have the capability of providing vaccines at their locations. And so we have been looking at what are the contingencies for those types of sites. And I've kind of alluded to this a little bit, but a mass turnkey vendor, we've been looking at students, like pharmacy students in particular, that have credentials and are able to vaccinate. We have been looking at strike teams for our health departments. And we will also be looking at any of the additional pharmacies that have capacity to vaccinate those that are in phase 1A. And actually in phase 1B, we've actually already turned on our allocations with the federal partners for the pharmacies to help us vaccinate those that would fall into phase 1B in time. So a lot of stuff going on. There's a lot of training, a lot of materials, a lot of new information. We have a system that is not traditional to anybody really, and a lot of this information, which we're calling VAMS, which is a Vaccine Administration Management System, is a CDC platform that they are going to be requiring, and so South Carolina is requiring folks to enter their information into VAMS. What will happen at that point is it would give us the level of detail of who has gotten a vaccine, and that will then transmit that data to our state's registry. And then we will in turn pass that information, de-identified information, along to the CDC. As far as ordering additional vaccines, those requests would be placed through VAMS, and then our team back at DHEC will look at those requests for vaccinations, and we will place orders in what they're calling VTRAX. And VTRAX is our CDC system that we use to order your flu vaccine or any of your other vaccines. So that's one thing that they kept normal for us, and so we're appreciative of that. There is also a vaccine finder account that has to be set up for each site that is going to be receiving vaccines. And the provider sites will actually have to upload their vaccine inventories that they receive into Vaccine Finder. And for now, it is not going to be public, and it will be up to the discretion of the provider to make that public. But the idea behind this, and this is a CDC requirement, is that in time, providers, as more vaccine becomes available and we're wanting to reach the masses at that point, and we want people to know where they can go to get vaccines, the providers would be able to turn on their site, if you will, make it open to the public, where a person could come and schedule themselves for a clinic and receive vaccines. And so that is something that we do want any provider that's going to be receiving vaccines to understand, that there are certain requirements that have to happen, such as the enrollment, such as putting the information into VAMS, and using the vaccine finder. In time, there is hope that we would be able to get out of the VAMS system, and then potentially end up making our way and using our traditional methods of using our state immunization registry system. And this would allow you at your level to be able to use your EHRs. So you would be able to process your vaccines just like you do now, notated in your EHR, and that information would pass along to the state immunization information system, known as Simon, for those of you that are familiar with that state registry. I think I'll stop there at the moment. I know that Whitney's on, and I know there were some questions about closed pods, and so I felt it would be really important to have Whitney on to help talk through some of the closed pods. Whitney, are you there? I hope so, or I'm in trouble.
Hey, this is Whitney. Can you guys hear me?
Hey, Whitney. Yeah, we can hear you. Thanks.
I'm sorry. I had to hit the *6.
All right, Whitney, take it away.
Yeah, sure. So I am Whitney Cofield. I work in the Bureau of Public Health Preparedness here in Columbia. off of Bull Street. So my daytime job is I'm the external plans and operations manager within the bureau. And wartime, I guess you could say I'm mainly at the state's EOC, working at the ESF 8 desk. That's the Health and Medical Services, and coordinating with other state agencies during response. So I'm going to briefly talk about the medical countermeasures closed pod program pre-COVID. So before the coronavirus pandemic, DHEC normally partners with community partners, hospitals, private industry on becoming closed and open pod partners. And pod just means point of dispensing. But the MCM program has been around for a while. So MCMs are a U.S. FDA products, whether it's biologics, drugs, or devices that may be used in the event of a potential or accidental public health emergency, terrorist attack, things of that nature. So it's short notice or no notice at all. So for that process, it's pretty simple. I say simple, but it's more detailed planning than that. But our regional MCM coordinators throughout the state, we have coordinators in the PD, upstate, Midlands, and Low Country. They work with individual hospitals, partners, nursing homes to become a pod partner. And we go over the operational planning piece. To be a closed pod partner, it's just a one-page registry form. But to be an open pod partner, and I'll explain the differences in a bit, it's more of an MOA process. So a closed pod partner is a partner that will want to receive an MCM or a drug or any medication for the public health emergency just for their facility only employees. So it's a really easy concept. It's closed off to the public. You just provide services to your employees or their families if you choose to be a closed pod partner. Now, open pod partner takes a little bit more detailed planning because open means that it's open to the public. So, for example, it could be a school or a larger hospital wanting to be an open pod partner and provide services, medications to the public during the public health emergency. Just a point of clarification. So we've been getting a lot of questions from our existing closed pod partners or pod partners about COVID-19 vaccines. The federal government chose to do something a little bit different for this pandemic in regards to medical countermeasures and pod planning. There is an additional step, Stephen and Dr. Traxler mentioned that there is a CDC COVID vaccine provider agreement. For our existing closed pod partners who want to receive COVID-19 vaccine, they have to go through the state's enrollment process. So there's an additional step that has to be taken if you're an existing pod partner and want to be able to receive and administer the vaccine. So on the line, I do have several or a few of our regional preparedness planners. So we have our Midlands and our upstate preparedness offices, but those guys are the go-tos locally on detailed pod planning, whether it be open or closed. And I'm going to put some information here in the chat for folks who are interested. I believe Prisma Upstate is already a close pod partner already. And Crystal Bowman can correct me if I'm wrong on that one. But like I said, if you guys don't know who your regional preparedness office guys are, you definitely know who they are. And we can share their contact information in the chat and via email after this call. So I'll take questions, comments about pods in general. Hope I didn't confuse anybody.
Sorry, thank you so much, Ms. Cofield. I was trying to unmute and it just didn't, I guess, hear for me. It would not unmute. I want to thank all three of you for sharing this information. This is so important. And yes, Ms. Cofield, I think everyone would love the contact information for the regional partners, or if there's a site that folks can visit to discover who it is they need to reach out to if they're interested in becoming a closed pod, that would be great. I'm looking through
I'll put
the
some information in the chat for you guys.
fabulous. Thank you so much. Yes, and we do have some Midlands organizations or campuses with Prisma that are also closed pod partners already. So I'd like to open up the chat box. Just if you could put your question in the chat instead of unmuting and asking it, to be able to keep track of them a little bit better that way. I had one already that I wanted to throw out while others are entering their questions into the chat. I was asked about, someone knows that Prisma Health is not making the vaccine mandatory for all employees, and that's absolutely true. And I could tell you that even months ago when this was being discussed, the reason for that's the question, what was taken into consideration, was just that in general, with a brand new vaccine or therapy like this one, it doesn't make a lot of sense to increase angst by making it required. That this is something that we felt like, at least for us as a healthcare organization, we would have plenty of folks on board and be able to educate and encourage so that we have a strong vaccine rate without making it required. We also found out recently, and Dr. Traxler, correct me if I'm wrong, that DHEC is not allowing us to, or anyone to make it, making it required. And maybe that actually was a CDC thing and not a DHEC thing. But we did hear that there have been limitations voiced on that, and that we really should not make this a required vaccine at this point. The follow-up question to that was, will we reconsider that in 6 months? I think that everything is going to be reconsidered, not just in 6 months, but in 1 month and in 2 months and in 3 months and in 6 months. And as we move forward, we'll have more information and be able to navigate that a little bit better. You know, this is the flu vaccine where we've have decades of information and know that this is the best course of action for a healthcare organization to make it, required. We need some time to be able to do that. So that's those are the considerations behind Prisma making that decision. I'd love to hear from Dr. Traxler, Mr. White, and others concerning what you know about requiring the vaccine in different populations.
Karen, I am not aware. Stephen, is it from us or the CDC that they are not allowed to make it mandatory?
So that's a great question. So to date, nobody has heard anything about anybody making anything mandatory. In fact, I think we've left it up to the discretion of the facilities to make any of those determinations, much like we've made determinations on, who they choose to vaccinate, right? And for their allocations that they're going to get. I do think it's important, however, that when we talk about this and when we talk about the general public, when they're going to be looking back on this to see who do they usually look to? They look to their healthcare provider and nurses and the healthcare community on, well, should I get a vaccine? And if there's hesitancy on the healthcare provider side, that could transcend down to the general public as well. So I know that we are highly encouraging folks to consider taking the vaccines to protect themselves and their loved ones. But at this time, no mandate.
As I say, I have not heard of us mandating that you couldn't make it mandatory, but that could be something from, like I said, higher than us. That could, as you said, maybe from the CDC. I'm not aware of it being, a legal requirement, though. As Stephen said, those kinds of decisions are best left up to, we feel, the local folks, and whether it be a business or a healthcare entity. We provide the factual information, same as we do for any other kind of mandate decisions, whether or not to mandate masks. I mean, we just provide the factual information and let folks then take everything into consideration for what's best for them or the people around them. But I do agree with Stephen that I think not only healthcare providers, but I do think that that leaders in all really types of employment, especially, in businesses, especially large ones that are very, high profile kind of in the community and all, really are those influencers that people will be looking to. And so we do want to encourage, somebody's backing up. We do want to encourage everybody to get vaccinated. I mean, that's how we're going to see an end to this pandemic, honestly, is, and I have enough confidence and faith in the system and with the studies it's gone through, and have, looked at some of the data that the New England Journal of Medicine put out and all. And when it's my phase, I will gladly be rolling up my sleeve and I will go on camera to do it. And so I encourage you, anybody, in the business world who is kind of one of those influencers, I really do encourage you, set the example if you're willing to, for your employees and the public, by going on record, going on camera, whatnot, or even just stating that you got it. And there was a question in the chat box about the adverse effects,
Yeah.
and so forth. There is information out there. The data is out there, from the clinical trials. We do know that this vaccine can cause a little bit of just a local, or mild systemic kind of reaction that lasts about a day. Not everybody gets it. Interestingly, I was reading some of the stuff, and the 18 to 55-year-olds seem to be more likely to feel it than the older than 55-year-olds. But just some soreness in your arm, maybe a little bit of fatigue, very low grade fever, chills. But like I said, starting a day or two after you get the injection, lasts only about a day, and it's seen more after the second dose than the first one. But I really encourage you. Those are very mild. These are very transient symptoms. So I wouldn't let them keep you from getting the vaccine. And there are systems for your provider and such to report all adverse effects to the CDC. There's actually 2 systems for this one in place.
Yeah. Thank you. And thank you for clarifying whether or not we're allowed to make things required. Yeah, you just never know what folks' interpretation is on those kinds of things. There is a question in the chat box around the temperature requirements of the vaccines that Dr. Traxler mentioned. If an organization were to become a closed pod, and I believe someone with your team actually answered the question there, that the cold storage would be managed via that distribution mechanism, and that it can be refrigerated, I'm assuming, for 5 days. Right. And then also, I believe Ms. Cofield, excuse me, I'm sorry, left some information here about the cold chain management in the chat. So if you are interested specifically on how that aspect of vaccine administration would work if you were a closed pod, please click on that. I also see that they left information on how to reach out to get to talk about whether your organization wants to become a closed pod and you feel like you're in a readiness, a state of readiness and preparedness to do that. That information is in the chat, so check it out. But for those of you who aren't able to see it, maybe you're on the phone, it's scdhec.gov/vax, which is VAX. Okay, let me try that again. scdhec.org /vax, and VAX is VAX. But you guys have made that harder on me. Holy cow. There's also an email.
I had to say it in a webinar earlier today, and so I know it is tricky.
That's a tough one. I think it's the / that got me. There's an email as well, MCM, which you'll remember is the program that Ms. Cofield mentioned, mcm@dhec.sc.gov. Okay, wonderful. I had a couple of other questions that folks sent me. The first is, we're hearing about this 2-shot vaccine, and I'm getting questions around, is the plan to be sure that everyone within a phase can get at least 1 and then we move to the next folks? Or is the plan for everyone to get 2 before we start looking at immunizing the next group of people?
So the federal government is holding back basically dose 2s for us. So that helps. We can't accidentally give it to somebody else as a dose 1. But so they will be shipping the corresponding doses to sites, and just right in time to give it 3 weeks after the first dose. So, the vast majority of people, before we move, for example, to phase 1B, the vast majority of phase 1A will have received both doses. I guess conceivably there could be a few people who just within the last couple of weeks have received their first dose, but not to worry. Their second dose is separate. It's a separate allotment. It's being held by the federal government. Yeah, because you
Great.
definitely need both doses for this.
Got it. And someone did ask, what is the time between dose 1 and dose 2? Dr. Traxler, for Pfizer, I believe it's 4 weeks or 28 days for Moderna. Okay.
Correct.
There's a question, what is the recommendation regarding the vaccine for individuals who have previously tested for COVID? This is a great question.
Sure. So there is not, as much, I would say, as robust data, but right now they are not giving any different recommendations for those folks. There were people who had tested positive who were in the trial, and there were no, adverse effects. So those folks are still encouraged to go ahead and get vaccinated.
Is there any messaging, Dr. Traxler, asking those folks to maybe wait, or are we just taking the recommendations for phase 1A and preliminary for phase 1B and applying them across the board?
So that could be something that individual sites, individual healthcare entities or businesses could take into consideration if they don't get enough doses. If you're a Prisma Upstate or Prisma Midlands, and you might not that first week get enough doses for everyone, and it's going to take you, let's say, several weeks to vaccinate a whole group. You could consider within that, sub-prioritizing basically.
Yeah.
But there's not a formal recommendation for it.
Okay, gotcha. All right, not seeing any other questions in the chat box. I do want to answer a question that has been emailed to me frequently since last Thursday, and that is, when will Business Health be ready to vaccine our business clients and partners? And I would like to just echo what Dr. Traxler said. Our intent is to do everything we can to help you with this process and to keep your workforce and your employees safe. But we have to be patient, and the guidelines are being described for a reason. We are, vaccinating the highest risk first. We also don't know what this would look like, and certainly, Mr. White and Dr. Traxler, if you have heard whisperings about what it might look like, let us know. But we don't know what this will look like for our phase 2B, phase 2C, or excuse me, 1B and 1C, it sounds like, in phase 2 folks, in terms of an entire workforce. So we don't know, will we be encouraged to vaccinate a whole workforce if they, for instance, the organization is a critical infrastructure organization, even if not everyone on that workforce is a critical infrastructure worker or at risk because of health concerns or age. Will we be doing it in sort of buckets? We don't know. And so we're not sure what this will mean for efficiency. But I can tell you that the vision from our team is to make this happen as soon as it can, and to help mitigate this as soon as we can for you all, whether that's mirroring kind of the flu clinics that we've done for you. You've heard a few of the reasons why that's a little more difficult than a flu vaccine, some of the storage requirements, whether it's using a mobile unit, whether it's managing you all coming to our facilities. We will tell you that Business Health Solutions is on the list to become enrolled as a vaccine administrator. So we do want to be able to provide this service and help you to the best extent we can. We just don't know what it's going to look like yet. So any advice from Dr. Traxler or Mr. White on that, if there's anything you want to add, please feel free.
But apparently my dog wants to add something. I apologize.
Oh, that's fine, anytime.
I think that he is trying to give the message Semper Gumby, which is one that I've taken up recently. It's one that one of our longtime epidemiologists was saying often, 11 months ago when we were first working on this, and everything was so rapidly evolving in January. And I think it's back in play, and that's just always be flexible. Because there is, as you said, there are a lot of unknowns still, and so it does require just patience and knowledge that that everything is getting worked out, and you'll be told everything you need to as soon as we have the information. But yeah, it's an ongoing process.
Absolutely. Well, and it has been since March. And those of you for these webinars, you know that if you watch one that I made back in August, it's probably irrelevant at this point. Everything changes so quickly. Well, I would love, I'm sorry, was someone going to comment? Okay, I would love to thank Dr. Traxler, Mr. White, Ms. Cofield, and everyone else from DHEC who was on the call, and I saw that some were helping to answer some of these questions. Thank you so much for being here. Thank you for the work that you're doing. We know that you are incredibly busy. We also know that you're being incredibly thoughtful and conscientious about how you are managing this for our state and in your partnership with us. I want to remind everyone, all of our business leaders, that we will continue to have videos, probably not until after the beginning of the new year. But at any time, if you would like to reach out to us, there is a contact us button on our Creating a Safer Workplace webpage. And that will send any questions to our team. We can schedule calls if that's what you need. I'm happy to answer any of your questions. And you can see I've got a straight line now to these wonderful folks at DHEC. So if I don't have the answer, I can get it from them. And I just want to say thank you to everyone for joining. Please reach out to us if you need any help, and have a wonderful rest of your day and a wonderful holiday, regardless of which one you're celebrating. Take care, everybody.
Wow.
Thank you, everyone.